Dear colleagues, in partnership with Nephrology Dialysis Transplantation, NDT, the official journal of the European Renal Association, ERA, Markus at Home welcomes Professor Rosa Torra in Barcelona, Spain, and Professor Dr. Roman Müller in Cologne, Germany, in order to discuss the management of autosomal dominant polycystic kidney disease, ADPKD, based upon the recent KDIGO guidelines co-authored by Dr. Torra and the consensus statement on nephrectomy in ADPKD of the ERA Genes and Kidney Working Group with Dr. Müller as corresponding author. The KDIGO guidelines have been published in Kidney International some months ago, and the consensus statement on nephrectomy in NDT. And this statement has been picked by NDT's editor-in-chief, Professor Anders, Professor Krumbichler, and by me as our paper of the month for a detailed NDT Markus at Home webinar. So Rosa, Roman, a great pleasure and honor to host both of you for a third webinar at our channel. Welcome back home.
Well, I would like to introduce both of you. So Professor Rosa Torra is Professor of Nephrology at the Nephrology Department at Fundació Puigvert, as Gunnar mentioned, in Barcelona, Spain, and Roman Müller is Professor of Nephrology at the Department 2 of Internal Medicine at the University of Cologne in Germany.
Thank you very much for this invitation. ADPKD has been my major topic for my professional career, and I'm very happy to be here at Markus at Home. I will provide you a brief overview of the guidelines because, you know, it's a lot of work. It's like 3 years work and a lot of pages. So I just will go through what I think is really new and the most interesting things. These are my conflict of interest. I will start focusing on ADPKD nomenclature, which I think is quite disrupting and new, especially for people not very involved in ADPKD. So we keep the name of ADPKD, autosomal dominant polycystic kidney disease, and we recommend just to use ADPKD when there is a high clinical suspicion and the individual has not been tested. When the individual has been tested, he can be either PKD1 or PKD2. The major part of individuals are either PKD1 or PKD2. And then we write it like this, ADPKD-PKD1 or ADPKD-PKD2. Okay, so these are the major genes. Then we have minor genes that have moderate evidence of disease, causing the disease, but they have been accepted as a cause of ADPKD. What we need to bear in mind is that most of these genes, except the last one, the NEC8, they all, you see this old individual here, that means that they cause a milder disease than what we usually understand by ADPKD. So, and sometimes the phenotype is so different that there is no kidney enlargement, for example, very limited kidney enlargement in some of them, quite a lot of fibrosis depending on the gene, and liver cysts are variable, and some of them are very common, including severe polycystic liver disease, but in some others are very rare. So this is a NEC8 is a very special thing with quite a very severe PKD. So we need to keep in mind that even these milder forms, that some of them will never need kidney replacement therapy, they're still called ADPKD. But of course, we need to know, for naming this, we need to know the name, the genetic test. And there are other genes that cause a cystic phenotype, but there is so limited evidence, or the phenotype is so different from what we understand by ADPKD that they have not been included among this list, and individuals with just a mutation in ALK6 or ALK8 or PKHD1 are not considered right now to have ADPKD. Now I will move to diagnosis. There are a couple of algorithms that are very useful, I think. This is for at-risk individuals, meaning that either the father or the mother have ADPKD. So when we have an adult with a family history, If the family is not resolved, genetically resolved, then we can do a kidney ultrasound. And if it shows equivocal features, then we will go to genetic testing or MRI. But if the diagnosis is clear, the kidney ultrasound is very clear, it follows PEI criteria, then its diagnosis is confirmed. And if it has the patient has no cyst, the individual has no cyst, then we rule out the diagnosis. And for those genetically resolved, we can either do an ultrasound, which is easy, cheap, or we can do genetic testing. In this case, not sequencing the whole gene, but just searching for the identified DNA variant. And then the other side, situation is when we find incidentally cyst in an individual without a family history. If there is a family, so individuals with cyst, if there is an atypical presentation, let's say discordant imaging on GFR, for example, low GFR with normal cystic size kidneys, or atypical renal or extrarenal findings. In this case, the ADPKD diagnosis is uncertain, and we will recommend genetic testing. On the other hand, when the clinical phenotype is very typical, like multiple cysts and large cystic kidneys with or without reduction of kidney function, with hypertension, no strange extrarenal findings, then the diagnosis is confirmed. And in fact, it is not needed to do genetic testing or nothing else. And finally, especially in young adults, when they have few cysts, normal kidney function, normal kidney size, no extrarenal features, it is uncertain. It's probably ADPKD, a young individual with few cysts, but because we don't have family history, we don't know, and then genetic testing is recommended. Also, kidney MRI can be done. Of course, if we have family history, then we follow the previous scheme. So what are the situations where genetic testing can clarify the diagnosis and aid prognosis? When the phenotype is not clear, let's say limited number of cysts in a young individual, when in a family, although we know there is a huge interfamilial variability, when this is extreme, like, I don't know, 30 years difference of age of end-stage kidney disease, I think that deserves genetic testing, or we think, not I, we think. Atypical imaging, asymmetry, unilateral disease, discordance between the Mayo class and the ADPKD and the GFR. What I mentioned before, for example, these normal size kidneys with low GFR, this is not what we expect for a typical ADPKD, so genetic testing is advised. Negative family history, we don't have any information about the phenotype of the disease. On top of that, we may not be 100% sure it is ADPKD. Very early onset ADPKD, so in children severely affected. In these kids, probably they harbor more than one mutation, and this is very important to know. For related living transplant donors, in young individuals, in older individuals, usually it's not needed. It's quite crystal clear just with ultrasound. Family planning, I will go in depth into that, and for all people if they want. But the thing is that we did not recommend genetic testing as an initial diagnosis of ADPKD to everybody. Of course, the recommended technique is next generation sequencing, either panel testing, exome, whatever. And also bear always in mind that the negative genetic test does not exclude the disease. Hypertension, very briefly, because there is nothing new. Between 18 and 49 years of age, CKD J1, J2, and hypertension, the target blood pressure is quite very low. This is based on the HALT trials, less or equal to 110 and 75, but same age with no blood pressure below 130/85 and over 110/75, individualized approach, which means do whatever you and the patient feel it's better. And finally, yes, the recommendation to use RAS inhibitors as first line. progression of disease, the recommendation, because this is very important in the guidelines, we have recommendations and practice points. Recommendations are those that are based on evidence, strong evidence. So the recommendation is to employ the Mayo class for predicting prognosis, but ProPKD can aid the identification of people with rapid progressive disease, meaning that it can help, but the evidence is not as strong as for Mayo class. And there are also some advanced biomarkers using MRI in progress. Regarding treatment, we know that the only treatment available is tolvaptan. It should be offered to all adults with a GFR above 25 and rapid progression indicated by Mayo class or a GFR decline over 3 per year. Of course, there are benefits and harms of the disease. It's not an easy treatment, I would say. The aquaretic effects are important, and the risk of drug-induced hepatotoxicity is there, requiring monthly blood tests for 18 months and every 3 months thereafter. But of course, it has been shown that it slows down the decline of GFR and slows also the increase in kidney volume. There are still some uncertainties that need to be answered. And there was quite an agreement in suggesting a water intake throughout the day, about 2-3 liters per day, with 2 people with a eGFR above 30, without contraindications. But these drugs are not recommended to slow GFR decline. mTOR inhibitors, metformin, statins, SGLT2 inhibitors so far, somatostatin analogs, and ketogenic interventions so far. What about polycystic liver disease? PLD sometimes is the most devastating clinical feature in patients, especially in women. The symptoms are pressure against the diaphragm and lung, shortness of breath, fatigue, the abdominal fullness causing fatigue, anxiety, concern, and dissatisfaction with abdominal size, pain, problems feeding, and also cyst complications. Then people with ADPKD should be informed about the presence of liver cyst. However, most patients with ADPKD have no symptoms and require no treatment because always the hepatocellular function remains normal, even in very severe cases of huge hepatomegaly. Of course, huge hepatomegaly, liver cyst, occurs mostly in women. It develops earlier and is more severe in women than in men. Women with PLD should be counseled about the benefits and harms of sex hormone therapy. I'm not going in depth, but contraception and also postmenopausal estrogen replacement therapy needs to be individualized in these patients, trying to avoid estrogens as they have been proven to worsen PLD. What are the options? Several options. To be honest, none of them works very well, except liver transplantation. Somatostatin analogs may have an effect, but for these enormous livers, the effect is really scarce, and the other techniques, they go with a risk, and usually they need to be performed in very experienced centers. So we have liver transplantation for massive polycystic liver disease. It is quite an aggressive treatment, to be honest, but for these women that have a very bad quality of life, this is a very good option. Of course, it depends on the country. I'm talking from Spain, where we have a lot of grafts available. So for combined kidney and liver transplantation, this is recommended when the eGFR is below 30, a double transplantation. And the indication for transplantation is high symptom burden, sarcopenia, complications, local complications because of the size of the liver, and a contraindication of failure of alternative options. Intracranial aneurysms, the prevalence is increased in ADPKD, and the incidence of subarachnoidal hemorrhage also. But the recommendation, again, based on evidence, is only recommended for when there is a personal history of subarachnoidal hemorrhage or a family history. Only in those eligible for treatment and that have a reasonable life expectancy. With that being said, it can also be discussed, meaning there is not enough evidence with cases, de novo cases, meaning without family history, so you don't know what happened in their relatives or what could have happened, and no family history, which is more or less the same, personal family history of extracerebral vascular phenotype in specific settings, depending on the center, and at the end of the day, to anybody who wants it. But remember that a negative test does not exclude aneurysms for the rest of the patient's life. So it needs to be repeated every 5 to 10 years. Genetic counseling, this is my preferred topic because it was my chapter. So, but I won't go in depth, just to tell you that every patient with a genetic condition deserves to have genetic counseling. Of course, ADPKD patients also deserve that. And what are the options when an individual has ADPKD? So one is adoption and the other, the reproductive options. There are some that go without testing of embryo and fetus, which is one of them is accepting the 50% chances of passing over the disease. And the other one is a sperm or egg donation. Of course, in this case, the newborn won't have ADPKD, but the parent won't be, the biological parent won't be the father or the mother. The other option is testing the embryo or fetus when we know the causal pathogenic variant. Of course, this is mandatory. If you want to offer PGT or prenatal testing, you need to know what's the mutation in that family. So yeah, the option is testing the embryo or testing the fetus. One of them, you select the embryos and just place a healthy one, a non-affected one. And prenatal testing includes pregnancy interruption for those for the affected fetuses. Finally, these are my take-home messages. The nomenclature proposed by KDIGO captures the genetic complexity and high phenotypic variability of ADPKD and assists in its management. The imaging criteria for diagnosis do not apply to individuals with mutations in minor genes, not PKD1 or PKD2. Genetic testing is not always definitive, negative or uncertain results do not rule out ADPKD. It is particularly informative for people with equivocal diagnosis, and it is essential for PGT or prenatal diagnosis. The Mayo class is particularly useful when the GFR is still normal, when the GFR already is abnormal, then this is much more useful than any other prognostic technique or tool. Intracranial aneurysms are increasing ADPKD, and they should be screened if they have a family history of a personal history. Otherwise, if they want to be screened, it's completely fine. Polycystic liver disease is a big burden, especially for some females. It is hormone dependent, so we need to be careful with contraception and with postmenopausal hormone therapy. And liver transplantation is finally the only option that totally removes the liver and the symptoms. And finally, all patients with ADPKD have the right to receive genetic counseling. And really, finally, I would like to dedicate this and to remember Tess Harris. She was a patient, a great advocate for ADPKD, and she contributed to these guidelines, but unfortunately, she passed away last year. Thank you very much for your attention.
Thank you, Roselle. We will move on to Roman now, and then we have some Q&As at the end.
Perfect. So let me set a bit of a highlight on one specific aspect that is also shown in the guideline, for which we felt, since there is and there are other aspects as well, but then since there is specific uncertainty often in the community and little harmonized approaches, it would be good to look even a little bit deeper and help beyond the guideline and add to the guideline, build on the guideline towards implementation in routine care. And this topic is nephrectomy and ADPKD, to deal with the question of who, when, and how should this be performed. A couple of disclosures here, none of them really affect this topic in any way. So what does the KDIGO guidelines say on this? Just a quick short insight there. So we suggest that native nephrectomy in people with ADPKD receiving a kidney transplant, so that the specific situation of transplantation should be performed only for specific indications when the benefit outweighs the risk. And in general, beyond the specific situation, nephrectomy is a treatment option reserved for severe intractable chronic kidney pain in selected people, typically with advanced kidney disease or after kidney failure, who have failed to respond to other modalities. So what's the key message here? The key message is always carefully consider if there's really an indication for nephrectomy, especially in cases with maintained kidney function. This should obviously be the absolute exception and normally not happen. So building on this, the Genes and Kidney Working Group set out together with a team from the University Medical Center Groningen to come up with a consensus statement looking at all of the details in this topic, and the background is clear. I don't have to say much about this anymore. Massive kidney growth, we all know this, can lead to pain, abdominal discomfort, abdominal distension, but also other symptoms, dyspnea and self-image problems. And consequently, many patients with ADPKD do actually undergo nephrectomy, but there is no evidence-based algorithm to guide clinicians available to date. How was this done? This was a systematic literature review, which was extended to meta-analysis when possible. And on the other hand, an exploratory questionnaire was sent to urologists, nephrologists, and transplant surgeons to provide insight into current standard of care. This resulted in practice points about indications, complications, mortality, timing, and technique of nephrectomy. And those draft practice points were then tested in a consensus procedure through 3 Delphi survey rounds with experts selected by Genes and Kidney, but also going beyond, involving the European Association of Urology, resulting in the final 23 practice points and statements to guide the field. Now, what was the result there? When you look at the indications for nephrectomy in general, the one key practice point is to address questions patients might have now in the future. The possibility of a nephrectomy of one or both kidneys should be mentioned to all patients in the setting of transplantation. So the key thing is, not everybody needs this, and we need to address this, but we need to talk about it with everybody, because otherwise this raises questions, right? And there are good reasons why we would recommend it or not, but we need to discuss the option. The second point there is deciding which patients will have a nephrectomy of one or both kidneys should be a process of shared decision making. That's only possible if we talk about it, preferably after multidisciplinary consultation, depending a little bit on the individual case. Now, when it gets to the more specific indications, back to the setting of kidney transplantation, a nephrectomy should be considered in case of recurrent cyst infections, when the frequency of cyst infections is 2 or more in the last year, especially when those were severe, right, as indicated here. The same is true for cyst bleeding. So those are the 2 standard indications beyond pain when nephrectomy might be needed, and especially if those lead to hospitalization and occur frequently. We look at the transplant setting itself, in case the native kidneys extend to below the iliac crest. This is kind of like a signal when we may think about this, but again, volume reducing therapy, and this can be other things than nephrectomy as well, should be considered. Means this is not a sign everybody who reaches this needs a nephrectomy, but that's when we need to think about it even a little bit more. Given that on average, however, there is a decrease in volume of the polycystic kidney after onset of kidney failure. Independently from whether this is transplantation or dialysis, routine pre-transplantation nephrectomy is not advised, because the symptoms normally do not get worse after kidney failure, but rather better. And if there are still symptoms, they might be there for different reasons. Most ADPKD kidneys shrink after initiation of kidney replacement therapy. Now, how do we assess symptoms? That's a very important point because this is anecdotal in many cases, right? Patients tell us something, we have a feeling, this is an interaction and so on. But then this will completely differ from physician to physician. So we suggest using validated questionnaires there to objectively assess whether indications exist and come to longitudinal conclusions, such as the ADPKD PDS to assess pain and discomfort, or when it gets to gastrointestinal complaints, the PLDQ questionnaire, actually coming from the PLD field, can be used. Now, what about the timing? When do we perform this? So that's quite clear. We mentioned this already. Before reaching kidney failure, this is a real exception. We need to maintain kidney function. That's part of quality of life and obviously also outcome. So there we have to be very, very careful and not give our patients the feeling that this is a simple solution towards symptoms. We have to talk about the symptoms and address them, but this is an exception. When we are again looking at lack of space in the transplantation setting, the preferred timing for nephrectomy is just before or simultaneously with transplantation to minimize the time with reduced residual kidney function, right? I mean, remaining urine production, or even in the living kidney donation setting, that we can do this preemptively, with simultaneous nephrectomy being more feasible in well-selected patients, right? I mean, usually with a living donor in centers with expertise with this procedure. When we talk about how do we do that and what would be the goal there, it is difficult because it depends on center experience, right? The choice for a specific surgical approach, so laparotomy versus laparoscopy or robot assisted or not, is dependent on kidney size, the surgeon's experience, and the availability of facilities. But a laparoscopic nephrectomy is generally preferred over an open approach because we know that symptoms are better afterwards. Patients recover more easily and have less complications. So this, in essence, if the setting allows for it, would be the preferred situation. The third point there is that we would prefer unilateral to bilateral. And the reason is that the surgery is a much larger intervention. And there is, and even though small, but there is a risk of difficult to treat arterial hypotension. And that in a dialysis patient, for example, is really a problem and can get quite severe. So if there's no need, unilateral is the first step. Last thing, alternatives. Are there alternatives? I mean, volume reduction in general comes with sclerotherapy, for example, as well. These are individual cases. But when we talk about the later stages, when nephrectomy really becomes an option, so after kidney failure, renal artery embolization is indeed an alternative to surgical nephrectomy. However, we need to look at how much experience there is out there. And there's actually more reports than we'd expect. So 775 patients back then, but admittedly, all of them in France and Japan and individual centers. So this is not easily extended to everywhere now. And it has to be weighed against the lower success chance. And there's also a risk for complications with this procedure, specifically post-embolization syndrome, which, however, is normally easily handled. So concluding this, the general suggestions are we assess the indications through validated questionnaires, multidisciplinary consultation, shared decision-making. The key indications are lack of space, but we really have to wonder how often this needs to be a reason. Cyst hemorrhage, intractable pain, infections, gastrointestinal complaints, recurrent kidney stones, suspected malignancy, and potentially also changes in self-image. The pre-transplantation nephrectomy normally only occurs when there is no kidney function anymore. Usually we can try to avoid this and work towards the post-transplantation setting or a simultaneous setting. But if we do it post-transplantation wise, then we need to wonder whether really the symptom the patient reports that suddenly pick up, for example, weren't there before, are due to those kidneys or not, right? They normally shrink. So another MRI or CT might be wise. To the surgical approach, we've talked about that depends on surgeon experience a lot. Preferred is unilateral. We consider this an intermediate risk procedure, and patient and graft survival, as far as we know, and data is not as good as we'd like it to be, but are on par with transplantation alone if it's done in a simultaneous fashion. Renal embolization may be a potential alternative in the future. And this is obviously also a future research topic, as well as obtaining more evidence for the thresholds in those questionnaires we're talking about, right? When should we do this? Not clearly known. Examine the effect of nephrectomy on symptoms such as dyspnea and self-image, where we have little data, defining what's actually the space requirement for kidney transplantation, to harmonize a little there. And with that, I'd like to come to a conclusion. Thank all of you, and special thanks to the Groningen team, who's done a large share of the work there. Thank you very much.
Thank you very much, Roman, and thank you, Rosa. These were two great presentations, and thank you for the large amount of work you've both provided in these important papers and in KDIGO guidelines and in this consensus paper. So I'm happy to kick off the Q&A session, and the first question would be for you, Rosa, if you like. The question is on the blood pressure targets, because this, as you certainly know, in the general population is a highly debated thing, and in specific populations, CKD patients, and now even more specific PKD patients, it's very difficult to have a consensus. And you said there's not been much change. Of course, there's not been any important study in blood pressure, hypertension in ADPKD since the health studies. But now the guidelines have changed, and what the KDIGO guidelines, as you've said, are pointing to is 110/75 in patients with preserved kidney function in young patients. And in the other patients, it's to follow the KDIGO guidelines, which is 120. Well, the difference with the general hypertension population is usually when we choose a target, it's because there is a reduction in mortality or in MACE, so major outcomes. In the HALT PKD, this was not the case, of course, because the study was not powered for this, but the outcomes were intermediate outcomes. My question is, how debated was this in the KDIGO group? Because it's quite different from what we see in other situations and difficult to apply in practice, actually.
I can tell you everything was very debated. And of course, this was one of the strong points. But at the end, the only evidence comes from the HALT trials, and this is where this very strict blood pressure comes from, which is quite challenging frequently in real life. But for the other, as there were no evidence, yeah. You know, the guidelines, KDIGO guidelines and in general guidelines are always on the safe side. So they just support you to where was more evidence beside ADPKD. Yeah.
Yeah, I understand this, but just for example, the ESH guidelines, the general European hypertension guidelines, took the SPRINT study and sort of adapted it to the real life. So what's possible and how are the biases in this study, especially the measurement biases. And as we understand here in these KDIGO guidelines, it's also the case in the CKD KDIGO guidelines, just applying the results of the study, which is understandable. But I mean, for the general nephrologist in practice, it's often difficult to follow. So,
yeah, I understand. It's guidelines are sometimes quite frustrating because you expect strong recommendations and they cannot be there because there are just opinions, and then yeah.
Yeah, I fully agree. In the hypertension part of the guidelines, there is no suggestion on what to use as a second-line treatment because there is no major evidence, of course. Do you know whether there was a debate within the group in 2015? This was also what was written.
Yeah, well, I don't recall a special conflict there because lack of evidence. You know that it has been for a long time recommended or suggested not to use calcium antagonists. There is not even enough evidence to discourage that. Of course, not as first option, but yeah, it can be used as a second option also. Yeah, there is no lack of evidence is the main problem.
And
maybe Dominic, if I can quickly comment on that, I think some of these things and was there right? I mean, it's quite clear that a guideline is always much of a compromise, and then the question is implementation down the road. And there, ERA has also set up a program of commentaries that will try to help a little bit with that. So the first one on polycystic liver disease, to then turn this into things that can be more easily implemented and help people with that, is coming out soon. And I guess also based on what you said, hypertension may be another one that actually would benefit from such an assessment, right?
Yeah, well, I fully agree. It's always the problem between just using the proper evidence and putting it into guidelines or implementing it into practice. And different international societies will use different approaches, which is fully understandable. My second question for you, Rosa, would be about the preconceptional counseling, because you were very implicated in this chapter. How, again, for the implementation, how do you think this will change things for, I would say, for the patients, of course, but this is fully understandable. But for the centers who perform counseling and, of course, all the technical part of the preconceptional medicine, do you think this is feasible in real life in our countries?
The last word you said is the key one, countries. That is so country dependent. This is one of the chapters less easy to generalize, to say the same for all over the world. It's almost impossible. So yeah, I would say in Spain, it's easy, PGT, prenatal testing, genetic counseling. In the Netherlands, it's very easy, but that depends where you go. It's super difficult. It's not covered by the public system, not by insurances. So yeah, I think what this may change is that at least patients should know the chances of passing the disease and the options they have in their country, in their particular situation, and then take informed decisions. I think at least this is what we aim to encourage all nephrologists to provide or ask someone to provide, because of course most nephrologists don't have this knowledge. Then if you don't have this knowledge to provide this information, you should refer your patient to a genetics department and they will tell them.
Just to give us an idea, do you have an idea of how many nephrologists provide this information to patients, either via a survey from nephrologists or from patients?
Well, this is a project we're working on, but very few, I would say. It's not something easy to say. You need a special training. It's not that easy. So I would say very few, but in all, I hate saying this word all, but in many or most large university hospitals or reference centers, they have a genetics department, and there they can provide this kind of information.
Yeah. Thank you. Roman, my last question will be for you. I had the experience of the Bordeaux team on renal artery embolization to reduce the volume of the kidneys pre-transplant. You pointed slightly in your presentation on the center experience. You said there were a few publications from France and Japan, but are there centers that did not publish and that perform this in all European countries or not? Because in my center, we never did this before, and I was quite interested in their experience and of course in your paper, which pointed to the fact that it could be possible. How broad is this? And are people learning to do this worldwide now because it somehow works, as you said?
So but I don't have any structured analysis on that. But my impression is this is still very rare when I talk to centers. So outside those expertise centers that do it a lot, it's something that is not routinely offered just because the whole pipeline is not there and there's certain degrees of worries and then transplantation, for example, is a multidisciplinary setting. So somehow you don't only have to be convinced yourself, but you kind of have to convince the transplant team and the transplant surgeon and so on that you're not doing something that messes up their algorithm. So partly, I think this is part of the problem. Does this deserve more attention? Is it a solution for everybody? Surely not. Does it deserve more? Because it doesn't really take it completely away. It alleviates some of the volume. Sometimes there's not much shrinkage either. It depends on patient characteristics. So if you have patients with a large, patient preference, but also a large risk when you undergo surgery, then you're obviously in a different situation. And it may also depend partly on, do you have very experienced interventional radiologists versus a team that would do open laparotomy for nephrectomy, for huge kidney while if you have a team that does very sophisticated laparoscopic robot-assisted kidney nephrectomies with very small cuts and so on, the ratio changes as well, right, as to how large this intervention is. So it'll stay individualized. I think it does deserve more attention. And that's why we also decided to have the Bordeaux team, have other people, really the interventional radiologists on this team and not only do nephrectomy because we have to weigh this, but at the moment it's still limited to very few centers in my experience.
Okay, thank you very much. Thank you to both of you.
And those do a lot of them and are happy with it. That to be said, right?
So Andreas gave me 12 minutes, and I have a couple of questions for these 12 minutes. Just going back for 1 minute or so to the blood pressure. And as Dominic, I have some, difficulties really bringing my patients down to below 110. Are these office BP measurements or home BP measurements that you recommend?
Home.
Okay.
Home
That
BP.
makes it somewhat easier then, huh?
Yeah.
And then Roman, I have two questions with regard to your recommendations. Maybe I missed it, but firstly, you wrote and you told us that after renal replacement treatment initiation, the kidneys start to shrink. So do we have any idea why this happens?
Essentially, I think this is that whatever kidney replacement therapy you use will further limit the blood supply to the kidneys, and there's little perfusion in the end. And essentially, that's somewhat like a situation to a certain degree, like an embolization at some point, not as acute and so on, not such acute changes. But I think that's the key reason why this indeed happens. But it does happen. It doesn't happen in everybody. It's impossible to predict. Some people even have more growth. So this is just like for polycystic liver, it's really hard to tell at the moment. We don't have markers that tell us when what happens, but it is to be taken into account. And I feel what I often see, and that is a problem, is that patients after transplantation come with abdominal complaints and say this is the polycystic kidneys, and nephrologists say it's the polycystic kidneys as well. They have to be taken out. And then they're sent to a surgeon. And then you make one MRI scan and you notice they're like 40% smaller than before, and you have new symptoms. Let's look for the reason for your symptoms rather than do something because it looks like the simple answer. And I think that's also where a bit of the reservation in our recommendations comes from in general towards nephrectomy. While we really feel it has to be talked about and symptoms have to be taken seriously, it's often viewed as the simple solution, right? You do this and the problem's gone. And this is not necessarily the case. And especially, I mean, I still see patients that had interventions, not meaning sclerotherapy, but partial nephrectomies or whatever, before kidney failure. And that is something that usually really is not necessary. And we have other ways to deal with symptoms. You have rare cases with really intractable or seemingly intractable pain. But there are a couple of interventional things like even plexus blockade that do work in some patients very well. So asking a center of expertise there with the pain management as well before taking out a kidney that has kidney function is probably really wise. And that's where a bit of the reservation comes from.
And I learned that the surgery is really quite difficult and hard work for the surgeons. Do we know how often the adrenal glands are removed during surgery? So is it easy or difficult? I tried to ask my surgical colleague, but I did not reach him today. So is it difficult or easy for the surgeons really to remove the kidney without affecting the adrenal gland?
A difficult question, right? That's where all of these aspects in the recommendations come from in the statements that many things depend on center experience. That is one point behind that. I mean, one of the reasons for this severe hypotension that sometimes rarely, but sometimes occurs is that the adrenal glands are also affected in these procedures. And if you do that bilaterally, then that's a problem on top of the lack of the renin-angiotensin system, right? And then you really start having patients that depend completely on volume for blood pressure control, for maintaining blood pressure. And those are not really good candidates for hemodialysis. Or anything actually. But in general, I think an experienced surgeon can deal with this very well. And they have gotten to a point where they also with laparoscopic procedures can spare the adrenal glands, but it takes the experience. And yes, things do happen. Complications can happen, if you do a large number. But in my experience, I would always ask a surgeon experienced with polycystic kidneys to take them out rather than sending people anywhere, because the complication risk in general is obviously, because the surgery is much larger than a normal nephrectomy. But that, I think, is natural as well. And I would always recommend my patients, if you have the chance for a laparoscopic nephrectomy, avoiding the big cut, go for this. But in a center that has experience with this, because recovery is better. And then also afterwards, all the impact on the body wall muscles and so on is very different.
Thank you. And then I have a question actually to all of you who treat these patients. So when reading the KDIGO, I learned that you recommend 4 to 6 weeks of antibiotic treatment for cyst infections. This is honestly much longer than what we do here. So is this really your approach in daily clinical practice in Cologne and Barcelona and Rouen?
Yes, yes, it is, because the cyst, when they get infected, you have like lots of bacteria inside the cyst, and the perfusion of the cyst is very scarce. So the reach of the antibiotic into the inner part of the cyst is very low. And to sterilize this bacteria, you need a lot of days, many days. So at least 4 weeks. And depending on how serious it is, you extend it to 6 weeks, but at least 4 weeks, because not treating for that long, it means that you keep some bacteria inside, and after, let's say, some weeks, months, sometimes, they have another episode of cyst infection.
I would fully agree to this, and also add that, all of our criteria of saying 2 cyst infections per year don't count if people were treated for a week. Then this is not a fully treated episode. So that's where treatment still takes place, and antibiotic selection is also important. Lipophilic moving into cysts and so on. That's also a question, is do we really have penetration there? And that's where, in my view, fluoroquinolones still play much more of a role than in our general standard of care. But especially with the long treatment periods, you have to tell patients they have to be aware of, tendon pain and etc. But they do play a role, because they do work much better. Sometimes actually even co-trim is the solution if it's still, the germ is still sensitive. Then it does work quite well and penetrates this quite well.
I agree, and this is particularly important in kidney transplant patients with infections who can also have infections of the native kidneys and have to be managed differently.
How often do you do punctures of these cysts? So when you see a single cyst that is clearly infected, giving your CT scans or even ultrasound, so is this kind of a routine technique then in your centers, or is that rather reserved for particular cases?
Yeah, we reserve it for cases that do not respond to treatment. So if after, let's say, 3-4 days, the patient still has high temperature, and you are able to localize the cyst, because this is the second thing, you need to localize either with a CT or a PET CT, then you can drain it. Yeah, but first you have a try with antibiotics.
But then again, 4 to 6 weeks of treatment anyway. Even all right, so we have to change our approach apparently.
Even with drainage, and I think, another reason that where the drainage can help is sometimes you don't have any proof of what bacterium you're looking at, right? So if you don't have positive blood cultures, the correlation of urine cultures with what is in the cyst is very poor. So obviously this will help to know that you're really using the right antibiotic for 6 weeks. In more complicated cases, not in the routine case in the first place. And also down the road, if you're not really sure which one is the cyst, you have one you suspect, this helps to be sure you're looking at the right cyst, right? To distinguish, for example, as well, if the recommendation is nephrectomy to treat this, you want to be sure you're looking at the right kidney. And you're not looking at a liver cyst infection, because then you suddenly have an anephric patient, but still the infection, so it doesn't help anybody.
So I want to come back to that. Sorry, Gunnar, because I think this is a very, very important point. We had like the second patient now this year with a very resistant cyst infection requiring multiple antibiotics. So I think treatment duration is very important, and we should really stick to 4 to 6 weeks in order also to avoid recurrence, because we had a young patient recently with normal kidney function, and she came back basically after 1 week of antibiotic-free or washout period with another cyst infection. And I think particularly in this case, like PET scan is also of help, as Roman mentioned, you need to identify the trigger. And that also brings me to one of the questions I wrote down, basically. Would you consider in such a in a resistant refractory patient with cyst infection, like nephrectomy or unilateral nephrectomy?
That will be the last option if the patient has a preserved kidney function, of course, because you will advance many, many years the need of kidney replacement therapy. So we do whatever is needed. So we have quite frequently resistant bacteria to Cipro. Then sometimes we need to use cephalosporins or whatever, and it's IV, and we do in-house, at home hospitalization with IV treatments there, because 6 weeks in the hospital for when they feel okay and they have no temperature is quite complicated. But I know, again, this is not available everywhere. But definitely you need to treat for long with the adequate antibiotics, no doubt. But nephrectomy would be the last option with the GFR is preserved.
Yeah. I have actually not a single patient in mind, and we see quite a lot of them where this was needed. I would be open to trying anything before that, right? I mean, even extended treatment beyond those 6 weeks is, I mean, we know that from, if you think about other cases of really difficult to treat infections like spondylolisthesis, right? Sometimes the solution is even 3 months or whatever, and you're surprised that suddenly the infection is gone. And most cases that we see where people say, this is like the 15th episode this year, you have to do something, take the kidney out, there's always a treatment mistake. And if you do it right, then it's gone. And then it's also talking to the patient, right? I mean, sometimes you have to accept that there are infections sometimes, and patients have to learn when, and if you treat early, it's easier and so on. So, but again, I think exactly what Jose said, this is something we don't normally see, maintain kidney function and nephrectomy due to infection. There's other rare cases where this might be needed. I mean, we've seen that for tumors, for example, where sometimes it's difficult to do this in a nephron-sparing fashion if anatomy is completely gone, but that's a different setting.
And I have 2 final questions, Andreas. The first one would be on nephroprotection. Again, we will not discuss today SGLT2 inhibitors because we will have Roman and Emily Cornec-Legal in a couple of weeks for a separate webinar on that topic. I learned that you do not recommend for the time being metformin, hydrochlorothiazide, statins, which are all undergoing clinical trials in ADPKD right now. What about finerenone, and what about GLP-1 agonists? And then my last question would be, again, reading your guidelines, you recommend people on tolvaptan to drink even before they have thirst. And in general practice, we also see so many people who are told time and again to drink. So why can people on tolvaptan not just drink according to their thirst? Is there any benefit by teaching them to drink even before?
If you want, I asked the one about tolvaptan, and Roman can answer the other one. Yeah, we tell patients not to get thirsty. This is not the same that drinking, over drinking, I would say. If they wait to be thirsty, that means you all know that there is a lack of perfusion in the, I would say, an insufficient perfusion of the kidney. So we don't want that. It's like repeated episodes of acute kidney injury. So yeah, we do not want that. And we tell them, just do not wait to be thirsty. But it doesn't mean that they have, usually they have no, I mean, they have no problem. They have a lot of problems, but they are thirsty enough to drink all day long. So I don't think it's a big issue.
Should I go back to the GLP-1 analogs and finerenone? I mean, essentially, if we have somebody that for whom there is comorbidities that are the indication, it's simple. Yeah, then most of these medications are fine, and there we also have, and we'll talk about the SGLT2 inhibitors in a couple of weeks, but there we also have options for SGLT2 inhibitors if there's other indications, right? When you think about the kidney disease itself, currently there's no clear recommendation to treat patients, general kidney disease patients broadly with any of these. So if we're looking outside the diabetic sector, and we wouldn't extend that to ADPKD. Plus, on top, we strongly believe that the pathophysiology is so different from what was examined in any of the trials that it's really hard to extrapolate. For SGLT2 inhibitors was even a bit special through the vasopressin increase. For the others, there is no specific thought right now why it would be bad, and I'm quite sure that finerenone could have a very good place there because we're looking at the fibrosis impact on ADPKD. Would I just do it? I mean, if we start doing this, I think the situation will be at some point that we'll have to wonder, will anybody be able to run this trial? And then we should wait for the trial. If not, we'll have to come to a consensus. What's our best feeling for it? But if there's a chance to get the data, we should get the data because otherwise we're treating our patients with 50 medications about at some point, of which, we only know for 20% what they actually really do in this setting. And I think that can't be the road to go either. Where we do use GLP-1 analogs more and more is actually obesity treatment in severe obesity, because ADPKD, obviously obesity has a major impact as well. And if there's no other way, and then all options are on the table, right, to help them. And that's patients in whom I often say, forget about tolvaptan. You have other things to focus on that probably have much more of an impact on your kidney function and your entire health. And that is now weight loss. So let's focus on the weight loss. If you can take tolvaptan, it doesn't bother you, it doesn't matter. But it does have an impact on people's life. So you might want to focus on something else. And that includes any option that there is for weight loss.
Okay. I think we're at the end of the hour. We learned a lot about PKD, and we will continue the discussion in a couple of weeks when we are regathering to talk about SGLT2 inhibition. And of course, we are very glad that we had two experts in the field, and we hope to see each other again next year in Glasgow at ERA 2026 when Rosaire will welcome us again as ERA president. Have a nice evening.
Thank you very much.
Thank you very much for the invitation.